Hello, everyone. Welcome to our week 3 lecture for outpatient billing and reimbursement. And this week we only have one chapter, but hold on to your pants because in week 4 you have 3 chapters, which are actually coding chapters, and they're in the book. Even though this is the reimbursement class, they're in the book. So we like to have you do those chapters, because repetition is key. Speaking of, this chapter is on the legal aspects of health insurance and reimbursement. You do have an actual um, legal course the second 8 weeks of this term. So, what this really does is kind of carve out the health insurance and reimbursement aspects. And so, you'll see a lot of these topics again. And when you took your introduction to health information technology, last semester, you actually were exposed to some of these chapters, concepts as well. So, the objectives for this chapter, there are 5 of them. So, of course, you want to be able to define the key terms. So, at the very beginning of the chapter, there is probably, I didn't count them, but if I had to speculate, I would say about 25 terms. And one of the things I will share with you, why it's important for you to learn these terms. There could be one question on the exam that, or actually multiple questions, that the fact that you knew the definition of a word made the difference. All right, so summarize the healthcare laws and regulations, and whoa, there are so many of them. Explain how a record retention is determined. 4, describe the healthcare audit and compliance program process. And as you grow in this industry, you may begin to explore different topics or lanes in this industry. And one of them could be healthcare compliance once you get some experience under your belt. So, lastly, explain the provisions of HIPAA. And I believe this chapter is going to blow your mind regarding HIPAA, because you're going to be like, wait a minute. I thought HIPAA was about XYZ, and it's actually way more than that. So I did not add a slide this week, and I don't think I did it last week, where I specifically called out, how these concepts apply. But I will tell you, domain 4 of the CCSP exam talks about compliance, and under the umbrella of compliance, you'll see things like task number 6, understanding HIPAA privacy and security regulations. I want to remind you that the AHIMA content outlines for your respective exams represent the floor of what you need to know and not the ceiling. A lot of people make a huge mistake of trying to memorize questions for the national exam. And I really think it's important for you to learn the information so that you can move beyond the exam, right? That you can learn some things to help you in the workplace. All right. So the chapter itself really has 4 parts, which are tied to those objectives, right? So the laws, regulations, retention, compliance, and then HIPAA. So let's dig in. It is important that you understand the different laws and regulations, because from the government's perspective, it's about what you should have known. So you can't say, I did not know. In your role, there is an expectation that you are knowledgeable of the laws and regulations and that you will actually follow them. And a lot of what we do is so highly regulated by the government that to some extent it can get a little overwhelming. So that's, the good thing is you have a legal course where you will explore these topics in more detail. So in our electronic book, when you get to the chapter on healthcare, or the section in this chapter on healthcare laws and regulations, you're going to see a whole bunch of terms such as statutes or statutory law. And I don't know if you figure this out by now, but if you actually click on the term in the electronic book that has I guess you would call it a hyperlink and it's underlined, you can actually write as you're reading the chapter, learn the definition of these terms. So they kind of cover some things that you'll want to know, such as, about court cases and court decisions. And in the book, they talk about a New York State public health law. I know we're in Chicago, but it's just good to see the laws. They talk about in this area a subpoena. So the patient record could be subpoenaed. That's called a subpoena ducis tecum. A subpoena basically says, you need to show up at a particular time and testify. But subpoena ducis tecum basically means you bring the record to court. There are other terms that are listed here, and as you read the chapter, you'll be able to explore them in more detail. So, two of the laws that you really want to be familiar with, the anti-kickback statute, anti-kickback statute, and the kickback statute, as the name implies, somebody's getting kicked back something. That's how I always remember it. But basically, um, it's a law that protects us and the federal health care programs from fraud and abuse by prohibiting the exchange of money or items of value for a referral. So I don't know if this has ever happened to you, but this happened to me. I went to the OBGYN at one point in my life, and I'm not going to say exactly when, but I'll tell you more about that. And I got a pap smear, and I don't know, maybe like 4 weeks later, I got some baby formula samples in the mail. Okay, number one, at that time, I was postmenopausal. I did not have a pregnancy test. And what that tells me is that my information must have been sold to a sales representative. I remember back in the day, they would give you a certain dollar amount per patient that you give them the name. And then, think about it. They spend a little bit of money to get the information. And in the list, somebody's going to be pregnant, right? Or pregnant in the future. And basically, what they've done is put that product in your mind. All right. So the anti-kickback statute started in 1997, and along the way in 1989 and 1995, additional provisions were made. So in 1989, we had the physician self-referral law, and basically what that means is a physician cannot refer a patient to a lab or even a pharmacy that they or a family member has ownership or investment in, right? So basically telling the patients, like, you need to go to this particular pharmacy or this particular lab, right? Because they would benefit, them or their family would benefit from that. In 1995, that's when they expanded it, and that's when they added all kind of um, areas that were prohibited for referrals. So, like, and you'll see this in the chapter: physical therapy, um, prosthetics. So, like, people own companies, and you can't refer your patients to a company that you or your family member owns. It's just not fair, right? somebody asked me recently, what about the hospitals? Like, there's a hospital that I went to maybe 5 years ago, and they have a Walgreens pharmacy in the professional building. And, someone said, well, isn't that like sending a message to the patients like, hey, why go out the building? You can get your prescriptions from there. I don't know if they're still open. I don't know. I mean, obviously they have that in there, so they must have cleared it with somebody. All right. So, harbor regulations. So the OIG, also known as the Office of Inspector General, on occasion will issue regulation called safe harbors. And these are arrangements and transactions that are prohibited by the Anti-Kickback Statute. So they will not be prosecuted by the OIG, even though technically they might be associated with the Anti-Kickback Statute language. And so basically, it's again continuing to prevent that referral. In the textbook, they actually have an example of this, which I know you'll read when you read the chapter. All right, so let's move it right along. So, some healthcare quality legislation and programs, the National Practitioner Data Bank. And I think I remember, yeah, I remember when that was established, because I started in healthcare in 92. But basically, this data bank is where all of the clinician, physician, nurse practitioner, physician assistants, information goes into, like, their license, where they're practicing at. Because one of the things that was happening was that some people they were being bad actors in one state or one organization, and then they just pick up and go to another one. And I remember being an auditor on a court case where a provider was doing some shady stuff, and then Hurricane Katrina happened, and that provider essentially disappeared, and then they actually wound up catching up with him in another state. So that data bank allows information to be in this system. So no matter what state you're in, you can look up to see if you want to bring a provider onto your organization. All right. So I'm just going to cover a couple of these. The Emergency Medical Treatment and Labor Act of 1986, also known as MTALA, basically states that you can't refuse uh, emergency services to a patient because they can't pay. And specifically, it prohibits what is known as patient dumping. And if you get a chance, Google patient dumping California, because there was either a movie or some type of news coverage of where this was actually happening, where they can provide the services but they refuse, right? And so they transfer the patient to another facility because they can't pay, or and I know that it was a movie, they like drop the patient off in a certain area and leave them be. All right, what else do I want to quickly cover? um Hospital inpatient quality reporting. This was a program that was implemented as a result of the MMA, or Medicare Modernization Act. And basically, it's for us as patients. It provides us with quality of care information so we can make decisions about our healthcare options, right? Because we do have options when you have um, when getting care. All right. So the other areas that are listed here, you're going to see about them in the textbook. Again, the lecture is no substitute for reading the book. All right. Record retention. So this is basically how we store documentation for a patient. And it is typically mandated by federal and or state law. And so the state in which the provider practices in determines whether federal or state law mandates the retention period. Please be advised that if you see this, and I'm going to go back and I have the content outline on my screen. If this is an area that comes up on the CCS or CCSP exam, please keep in mind that these exams are national exams. As such, you're not going to see information about your particular state. So we're in Illinois, right? In the textbook, they give an example of Massachusetts. But in day to day practice, the law that requires us to retain the longest is typically the one that we follow, the one that's more stringent, right? So let's say Illinois, ours is 7 years that we have to retain the record, but Medicare says 5. So um, we go with the longer period. And that number has changed. I think Medicare actually changed it to 7 years from the date of service. So, they could come back at any time and ask you for those records. And if you cannot prove that you provided the service, you didn't provide the service. All right. Let's see what else. So, HIPAA mandates the retention of claims data for a minimum of 6 years. And so claims, accounting records, we have to keep those for 6 years. All right. So, healthcare audit and compliance programs, one of my favorite things. So, the Department of Health and Human Services, also known as DHHS, if you are watching the news, you probably heard about Robert F. Kennedy being tagged to be the director of the HHS, and this is that HHS. So this particular part of the government was established to ensure the integrity of governmental healthcare programs. And as indicated on the slide, they do this by, and I'll let you read through that, right? Combating fraud, waste, and abuse, and finding and correcting improper payments, overpayments, right? So, again, just because you got paid for something doesn't mean you're going to keep the money, because they could come back and they could do an audit. So, um, organizations typically have a compliance program in place, and the government started issuing guidance for compliance programs actually in 1996. And in the compliance program guidance or guidelines, CPGs, they basically give us the 7 elements of a compliance program. And they notate that, every organization is different. So the compliance program at one hospital may look different from another hospital. Compliance programs for a doctor's office is going to look different than one, a solo practice versus multiple providers. And so they, advise us to take that into consideration. But at the end of the day, if you get called out, you need to basically prove that you have that program in place. If you get audited, and in the chapter they talk about audits, if you get audited and you don't have it in place, one of the things that they will mandate that you do is actually put one in place. So, when we're talking about the compliance program guidance, and you can go to the OIG website and or you can just Google OIG compliance program guidance, and you will see all the different guidances. So they have guidance for third party billing companies, guidance for nursing home, compliance guidance for physician, individual, and small group practices. So in the book, they basically tell us that for an individual and small group practice, there are four things that represent a risk area. One is proper coding and billing. Oftentimes, physician practices don't have a credentialed person working within the organization. And so, when you're credentialed, we're holding this higher standard of ethics, and we are making sure that what was billed was actually documented. Now, not to say that somebody who doesn't have credentials um, are not doing the same thing, but nonetheless, the expectation is if you're credentialed, you are, which you could not be if you are shady. Nonetheless, making sure that services are reasonable and necessary. So that's medical necessity. What happened and why? Making sure that documentation is in place, and then avoiding that kickback. Right, the self referrals. Right, it's that you see that it's really a thing. The MIP, the Medicare Integrity Program. And guys, it's so many names. I honestly can tell you that while I know some of the major ones, I don't even know all of them because I'm not using it in, day-to-day practice in terms of what I'm doing currently. And so, yeah. All right. So the Medicare Integrity Program, which was established as a part of HIPAA in 1996. It was about the three things: fraud, waste, and abuse. And as a part of this, Medicare, big Medicare, CMS, they require the different Medicare administrative contractors, that's who our claims go to verify basically inappropriate billing and develop interventions to correct the problem. So they do things like medical reviews. And one of the examples of medical reviews that they do is about medical necessity. And so a lot of times what they do is we send the claim to them with no medical record. And so what will happen is if they don't think something is medically necessary, they will ask us to submit the documentation electronically, and they will review it to determine if we did what we said we did. One thing you don't want to do is alter the documentation before you send it. You certainly should review it to see what if you did submit a fraudulent claim, um, so that you can immediately start to look at internally what's going on, right? Because then once the government says, "Hey, we found this claim," because let me just tell you this: they when they ask you for medical record documentation, sometimes they've been monitoring your claims data for a while. And so they already know something going on. So you don't want to, lie and alter medical records. All right. So they also do targeted probe and have an education process for medical reviews. The goal is to reduce claim denials and appeals. And I believe we talked about appeals before very briefly. Yeah, in week one, probably. And we will talk about it again. So the MIP, Medicare Integrity Program was doing very well. And so big Medicare, CMS, little Medicare is the Medicare Administrative Contractors. Those vary based upon locality. We'll see that later in the book. But that was doing so good, the Deficit Reduction Act of 2005 established a Medicaid integrity program. And so this is same thing: fraud, waste, and abuse. And they're doing audits, they're looking for overpayments and educating about quality and integrity. As a part of this, they established the PERM program, which looks at improper payments for the CHIP program or CHIP program, the Children's Health Insurance Program. This law also established the Medicare fraud control units. which is another arm that is um, looking, so investigating and prosecuting those that commit Medicaid provider fraud. All right, enough about that. But there's more. The RACs, the Recovery Audit Contractors. So, one of the things that the government does is start programs off as what they call a demonstration project. So, you see how on this map here you have the 50 states, right? They may start it with just 5 states initially. So I believe when the RAC was first started, they were, I think it was Illinois, California, New York. So they kind of tested the RAC program with a few states, and the RAC is basically finding and correcting improper payments, and it's overpayments as well as underpayments. And so after, I don't know, I think it was like 6 months, they were like, "Yo, we got to take this, we got to take this to all the 50 states." And so what you're seeing are the 50 states divided into different regions. And so the Recovery Audit Contractor, they are responsible for finding and correcting in their region. So as you think about job opportunities, once you get experience, all the things, to go to the next level, don't sleep on the Recovery Audit Contractor as a potential place of employment. And one of the things I will tell you that I think is so very important that you do is network, because you never know who works where. All right, then we have heat. Something that we need in Chicago right now. Healthcare Fraud Prevention and Enforcement Action Team. This is a joint initiative between HHS and the DOJ, the Department of Justice, to do what? Fight healthcare fraud. And so they're looking and investigating all types of fraud schemes. So sometimes you'll have like equipment companies that will like target Medicare patients, and they'll have the Medicare patients um, insurance ID. They'll bill to the government to say that they gave the patient a piece of equipment, and the patient got nothing. They literally like had their information and fraudulently um, billed for that service. You can Google that too. I remember there was a company who had an address in Florida, and it's durable medical equipment is typically what you see this with. Could be other things, but they had an address in Florida, and when the newscaster investigator went to the address, they literally found an empty office space with like a what do you call that thing? Like the little slot where you put the mail in. And they saw, Google it, I'm serious, Google it. And they, really realized that this was not um a real business. So basically, and the book says it perfectly. Criminals masquerading as healthcare providers or suppliers. In the book, they really do a great job of giving you like sample scenarios. So again, I know I said this multiple times, but I have to, because I want to make sure that you are reading the chapter, and you need to read the chapter to do the homework quiz or whatever you got to turn in this week. All right. So Medicare strike force teams. This is a whole team of people who are looking for these folks. Okay. And I talked about, criminals masquerading as healthcare providers or suppliers. They're literally looking for this. And you know what? Really, this is how oftentimes these organizations get caught. Grandma, for example, will look at their explanation of benefits. We talked about that. And they'll be like, I didn't have this, right? And then what does grandma do? Grandma's very diligent about paying bills, right? So grandma calls up Medicare and it's like, hey, I didn't get this, right? And then it's like multiple grandpas call and say, you said I got this, but I didn't get this, right? And then, they start to investigate. All right, Medicare Shared Savings Program. This was something that was established as a result of the PPACA law, which or act, which is the Patient Protection and Affordable Care Act. And this law act required Medicare to establish a shared savings program to facilitate coordination and cooperation among providers to improve quality care for Medicare patients to reduce unnecessary costs. And so, what does it do? It promotes accountability, it requires that coordination of care, and encourages investment in infrastructure and redesign processes. Reducing overpayments programs. So many programs, right? So overpayments are basically when you got paid more than what you should have gotten paid for. And as part of this program, um, we have 60 days to report and return overpayment. So this basically says that we're doing internal audits and are discovering this ourselves. Um, Medicare does have what is known as an overpayment demand letter. There's actually an example um, in the textbook, and from what I remember, working as a billing director, they basically take the money from payments that they are sending you in the future. So it's not like um, you can say, well, when we have it, we'll send it to you. They make sure that they get it back from you. Okay, NCCI. Uh-oh, wait a minute. Wait a minute. I remember when we looked at the CCSP content outlines, domain number 1 of the CCS exam, task number 7, demonstrate knowledge of coding edits in CCI, medical necessity is right there in black and white. So definitely something that you want to remember that you need to know. Again, the content outline represents the floor of what you need to know and not the ceiling. All right, I'm almost done. I try not for these to be more than 30 minutes. So, the NCCI program, National Correct Coding Initiative, was established in 1996. And it was trying to detect, or not trying, detects inappropriate codes, submitting on the claim form and denying them. And there are 3 types of edits which can result in claim denials. The procedure to procedure edits, you're going to see more about this in the book, along with some examples. Medically unlikely edits, also known as MUE, and then add on code edits. Okay. The other thing I will say to you is that because these are governmental programs, they have a website dedicated to NCCI. They have a website dedicated to HIPAA. So, speaking of HIPAA, in 1996, Congress passed HIPAA due to fraud and abuse concerns. And whew, it came up with a lot of provisions. So we already talked about the National Practitioner Database. We also talked about the Medicare Integrity Program, right? So basically, because the government is like the largest payer of healthcare in the U.S., they have to figure out ways to recoup money that was paid inappropriately. So in the textbook, they have this really cool diagram, which you're seeing right now, which shows you the 5 titles of HIPAA. And the title that we are particularly concerned about is Title 2. And Title II has three parts: preventing healthcare fraud and abuse, administrative simplifications, and then medical liability reform. So when you look at, for example, administrative simplification, that's when you see that the rules were refined for or established for privacy, security, as well as electronic data interchange. And then under electronic data interchange, which I believe was covered in chapter 1, that's when we got into standard transactions for submission of electronic claims. That's when we got into, there are 5 approved HIPAA code sets, right? So in this program, you are learning about ICD-10 CM, ICD-10 PCS, CPT, HCPCS Level 2, but you are not learning about CDT, which is current dental terminology, or NDC, which are the national drug codes. But HIPAA mandated that those are the only approved code sets in the United States. Then we have what are known as identifiers. These are mandated for our claims: NPI, National Provider Identification Number. So physicians, nurse practitioners, physician assistants, they have NPI numbers. And then we have the EIN, which is the Employer Identification Number. So literally, um, each of these laws, or these titles, I should say, has their own thing going on. So for example, title number 1 limits exclusions for a pre-existing condition, right? So when you go from one insurance company to the next, they can't say, well, you can get on this insurance, but you have to wait a year before we'll cover anything. All right. And then Title 2, I talked about administrative simplification. But then we also have the um, revised definition of fraud and abuse. In the textbook, they give you some examples of different types of fraud and abuse. Very important that you tap into this, because it's information that you definitely need to know as a professional in this industry. So, in the book, they will go into more detail about the 5 titles of HIPAA. And if you are, wondering, well, do I need to read that? Well, let me go back over to the content outline. CCS exam, domain number 4, task 4, ensure compliance with HIPAA guidelines. Domain 5, information technology, ensure compliance with high tech guidelines, which is also an extension of HIPAA. Let's see. CCSP exam, domain 4, compliance. Task number 6, demonstrate an understanding of HIPAA privacy and security regulations. Please do not sell yourself short by picking and choosing what you will and will not study. All right, so we went through the healthcare laws and regulations, record retention, healthcare audit compliance programs, and then the 5 titles of the HIPAA legislation. You, of course, are going to be reviewing the chapter and doing your graded activities for the week. And this has been your week 3 lecture for outpatient billing and reimbursement. Chapter 5, Legal Aspects of Health Insurance and Reimbursement. See you next week.